Hi, this is Dr. Deepak Megur, and today I'll be taking you through a very complex and a challenging case. But these are the cases which actually give us sort of a kick to think and plan and do surgeries. So these are the exciting cases which really wake the surgeon in us and make us think. And let's see how this case turns out. Now, she's a 65-year-old lady who presents with this cataract and she wants visual rehabilitation from this eye. Now, the history goes back to about 25 years when she has sustained a penetrating injury with a stick. She happens to be working in field, and since then the vision is bad. And she hasn't bothered for any consultation since then, and now she's interested for surgery in this eye. And let me try to delineate certain things which I'm seeing here. So this white band is the absorbed cataract. Predominantly just has the nucleus itself now. So there is no epinucleus or cortex. And most likely the capsular bag is very much adherent. Both the anterior capsule and the posterior capsule is very much adherent to this nucleus. Now, as I am scouting around this area, I can see there is a crescent-shaped area in the inferior quadrant. And this looks like the edge of the capsular bag. Most likely, this looks like an area of zonular dehiscence because this is where the capsular bag is ending. This is an empty area. There is devoid of any zonules. So I guess this is the area of zonular dehiscence. Rest of the area, the bag is empty. And as I come back to the cornea, there is an area of opacity. That's the site of the penetrating injury from which the stick has entered in and come out. Okay, now this is the case. Now, how do we plan surgery in this eye? I'd like to pause the video here, and I usually ask my fellows to just examine this case now and then plan out how we're going to do the surgery. Write down the expected challenges and how do you plan to deal with each of them. And what are the multiple backup options you're going to have when you're trying to manage this case. So if for the younger colleagues who are watching this video, I think that would be a good exercise to just write down your thoughts on how you're going to manage this case. And later on, maybe compare with how the surgery was eventually done. Let me take you through the things which were running inside my head. So I think in these cases, every option has to be kept open because traumatic cataracts are like Pandora's box. You never know what you're going to get inside. So to begin with, I have planned with an in-the-back fixation of the lens. I have planned in the sulcus fixation of a posterior chamber lens. And also, I am ready with an iris clip lens if the bag cannot be salvaged. Now, the challenges in this case are first to get the rhexis right because the capsule seems to be adherent to the underlying cataract, and these long-standing cataracts, tearing the capsule becomes extremely difficult, especially when you're clearly seeing that there is a significant area of potential zonular weakness here. Second thing, there could also be a possibility of an underlying posterior capsular tear, which is not visible now. And the third point, the entire bag seems to be very flimsy and thin. So saving the bag itself is going to be a challenge. So with that reason, I have kept my iris clip lens also ready after calculating the required A constant. So I'm ready with three possible options: in the bag lens, the sulcus lens, and the iris clip lens. My surgical planning is try to do a smaller initial rhexis, then try to create space within the bag by using cohesive OVD. If I'm able to create space in the bag, then maybe I will try to introduce a CTR to stabilize this area of zonular weakness and then deal with the nucleus. My plan for managing the nucleus is to remove it manually. I don't want to go in with phacoemulsification in this case. So that is my plan, and let's see how things turn out. The surgery is being done under a posterior subtenance anesthesia. The conjunctival flap is raised, the bleeding episcleral vessels are cauterized, and I begin my scleral tunnel. Now, since I know that the nucleus is very small, I'm not going to make a very big sclerocorneal tunnel. I've restricted the incision size to about 5.5 millimeter, and this should also suffice for the iris clip lens if at all I need to use it. The side ports are made. While staining the anterior capsule, I am a bit concerned about the dye percolating behind the lens into the vitreous cavity, and which could obscure visualization. So I'm using a very little amount of trypan blue. I'm just trying to paint the anterior capsule under the air bubble using few drops of it. I just plan to wait for a slightly longer time, maybe about 20 to 30 seconds, just to ensure that the staining is appropriate. The stain is then irrigated out using BSS. Again, care is taken not to build up the pressure. I'm just pressing down on the side port incision so that there is easy egress out of the fluid out. This will prevent the fluid from getting across this zonular dehiscent area into the vitreous cavity. Now is the time to inject OVD into the eye. The internal incision has to be created. I'm using a sharp 2.8mm bevel up keratome to make the internal entry. Care is ensured that the inner lip always runs parallel to that of the limbus. Time to perform the rhexis. I'm planning to do an initial small rhexis, and then if it is successful, I plan to introduce the CTR and then maybe enlarge the rhexis. So I'm using a sharp cystitome to puncture the antercapsule, and as I'm doing it, the entire lens is moving. So nevertheless, a small flap could be raised and the tearing can be initiated, and the tearing is continued in a circular manner until I reach this roadblock. Now this is an area where the capsule is extremely flimsy and there is no zonular support here. So it's refusing to tear ahead. I refill the bag with OVD and then trying to switch from a needle to a forceps, but the results are same. I'm unable to proceed and I'm worried that if I proceed, the entire bag is going to come out. At this stage, my subconscious mind is thinking whether it's really possible to save this bag. So I try the usual trick, that is to try to complete the rhexis from the other end. Luckily, I could complete the initial smaller rhexis by tearing from this end. The remaining little flaps on either sides are taken care of. Now it looks like a decent capsular opening. Now is the time to consider implanting a CTR, but before that I need to create space within the bag because the bag is shriveled and the posterior capsule and anterior capsule are adherent to each other in majority of the areas, and also the posterior capsule would be sticking onto the undersurface of the nucleus. So I need to create space and I'm going to inject cohesive OVD specifically for this, that is sodium hyaluronate. As I'm injecting, I'm carefully observing the movement of the OVD inside the bag. Some areas of the bag is formed, but at this juncture when I'm trying to inject OVD, I clearly see that the OVD has gone across the capsular bag and beyond it. So it clearly is an indication that there's a breach in the capsular bag in the equatorial region. And the crescent area which I was telling initially that's the area where the breach is, and you can see the OVD has gone out of the bag and it's in the clear space. So clearly when the bag is breached, the option of using the CTR is out now. So the in the bag placement of the lens also seems very unlikely because can't stabilize the bag. Now how do you go about? So this stage I'm just thinking now, the first thing is I just want to get the nucleus out and then if possible try to save the anterior capsule and the posterior capsule and then consider implanting a multi-piece lens in the sulcus. So that option I've still kept it ready. So under the cover of the OVD, the nucleus is gently manipulated out of the torn bag into the anterior chamber and it is then expressed out. Now, having a closer look at the bag now, the entire bag looks to be very thin, flimsy, and the posterior capsule has a lot of thin, flaky material which might not be possible for me to remove in totality. At this time, I am seriously considering whether to salvage the bag, that is to remove the entire bag and then fix the iris clip lens. I'm just trying to delineate the capsular opening where it is using a forceps. And I'm using a capsule polisher to just scrape off the posterior capsule and make it a little bit more transparent, just trying to get rid of these thickened cortical matter which is sticking onto the posterior capsule. Now before irrigating out all this muck which is inside, I thought I will go ahead and do a vitrectomy first because when we introduce irrigation anyway the vitreous might prolapse and may displace the bag a little bit more. With that idea in mind, I'm going to do a vitrectomy first. The cutter is placed through the clear area where the zonules were absent and the irrigation is held through the opposite side port. I'm going to do a limited anterior vitrectomy, just clear out the vitreous beneath the posterior capsule and around it. The idea is that during further manipulation, we shouldn't have any prolapse of the vitreous, which might cause a late decentration of the bag and the posterior chamber lens if at all I place it. Now I'm trying to irrigate the posterior capsule with PSS, just trying to clean up all the thickened cortical muck which is sitting on it, just trying to polish it using the hydrojet. I know the capsular bag is very flimsy and trying to fold across, but I think this is a very gentle way of trying to clean up the posterior capsule. Thankfully, the tear in the equatorial region is not extending, and now it looks like I have still a decent opportunity to place a posterior chamber lens over this anterior capsule. I am attempting to aspirate out some of this very sticky cortex using the bimanual irrigation aspiration. The settings are kept extremely low with very low vacuum and flow rate so that I don't pull out this very vulnerable bag out. So gradually and very carefully, each of these thickened cortical fibers is just teased out. But as I'm doing this, we can clearly see that the equatorial breach which was there in the capsular bag has folded inward, increasing the size of this clear area, indicating that there is a fresh prolapse of vitreous. So this is a clear sign that I need to go back again with vitrectomy cutter to deal with this prolapse vitreous, because that is what is pushed this bag into the central region. I go in with my cutter and then perform the limited antivitrectomy. So once the vitreous is taken care of, we can see that the capsular bag just falls back to its original position. With the vitreous out of the way now, again I switch to my bimanual I&A and then again go back to teasing out this thickened cortex which is there in the remaining part of the capsular fornices. Now is the time to enlarge the anterocapsular opening, and I'm going to use the vitrector itself to nibble at the anterocapsule and enlarge it. So I'm going to use the IA cut mode, that's irrigation, aspiration and cut mode, just to engage this anterocapsular flap and then keep nibbling at it so that eventually I have a decent sized opening. Since we don't have an intact rhexis all around, the plan is to just place a multi-piece lens in the sulcus over the anterocapsule and the underlying posterior capsule support. Although the centration might not be great, but still that is the best option which we have. The second option always is to just sacrifice the entire bag, pull it out and then place an iris clip lens. But somehow I feel that the amount of inflammation and the overall outcome is still going to be significantly better if we have a posterior chamber lens. Of course, the mandatory thing is it has to be decently centered. So I'm still going in with my conviction to place the posterior chamber lens itself. Let's see how things turn out. Before putting in the lens, I need to deal with this posterior synechiae where the part of the iris in one quadrant is sticking onto the flimsy anterocapsule. So I'm using micro scissors to cut the adhesion, and then again I'm ensuring that its adhesion is totally free by injecting cohesive OVD. And now things looks to be alright, and there looks to be enough space to manipulate the multi-piece lens in. I prefer to use the cohesive OVD in such situations because the chamber maintenance is better and we don't have a shallowing of the antechamber, and especially in these eyes who have undergone vitrectomy, there is a greater tendency to be hypotenuse, and this helps us to create some space. Both the haptics are in now. I'm just trying to dial and ensure that the haptics are away from this area of the capsular bag defect. Time to remove the OVD. I'm just lifting the intraocular lens and going it with my irrigation just to flush out all the OVD which is there behind the lens, and also some of it would have gone into the vitreous cavity. Then the OVD in front of the lens is also similarly washed out. At this moment the lens looks to be very well centered and it really looks nice. The central visual axis also appears to be optically quite clear. So the patient should have a good visual recovery. The side ports are hydrated. Before closing, I am just injecting diluted triamcinolone acetate just to rule out any prolapsed vitreous fiber. Thankfully there is none, and time to close. Glue is being used to close the conjunctival flap, and that's it. These are the first day post-op pictures. The eye is quiet, there's no inflammation, the lens seems to be well centered, and the uncorrected visual acuity is 6/12, and the patient is quite happy because she was counseled of a very poor visual prognosis, but she was quite happy with the outcome. So to summarize, this was a case which was challenging in many ways, and salvaging the bag looked quite difficult to begin with. But nevertheless, with a little bit of a patience and appropriate planning, we can manage to save these very flimsy bags and place the lens into the sulcus. Of course, just sacrificing the bag and putting an iris clip lens also isn't a good option, but this is something which I tried and worked for me. So that was it. Thank you for your attention and hope you found this helpful.